Alrighty.
Very excited about diarrhea.
Yep. This is a good topic. All right. Unpause this. All right. Can you see my slides? Hello?
Yep.
Okay, great. You can see the slides.
Mhm.
Okay. All right, cool. We're going to be talking about the initial evaluation of chronic diarrhea. I'm Ahmed Hassan. I'm one of the GI fellows, and basically, we're talking about when a patient initially presents to a general medicine practice for the evaluation of chronic diarrhea. So first on spelling, this is from Lifehacker. Uh, so I guess in Australia they spell it with an O, so don't be confused. But diarrhea, for those who are interested, comes from the Greek word diarrhea, which means a flowing through. So that's where it comes from. The spelling is almost as unpleasant as the experience itself. It's one of those words that makes you grateful that spell check exists. And for those of you who like mnemonics, you can use a mnemonic that it really, really hurts to keep the RRH sequence in mind. All right, so that aside, when we talk about definitions, are we asking, when we're asking about diarrhea, are we talking about urgency? Are we talking about frequency? Are we talking about the consistency? What are we really talking about here? So if somebody comes and tells you they have normal consistency stools, but are just having a lot of them, they're telling you that I'm having 5, 6 regular bowel movements a day, and they think that's too much. That's what we call pseudodiarrhea, and it's important to know that because what that, it's going to lead you down a different pathway. Whereas the consistency is really what we're focused on when we're talking about actual diarrhea. If it's longer than a 4 weeks duration, then we call it chronic diarrhea. If it's less than 1 week, we call it acute diarrhea, and in between, we call it subacute or just in between diarrhea. So it's a matter of consistency is really the main question in diarrhea. Most uh, regular infectious diarrheas resolve in a week, and almost all of them resolve within 4 weeks. So that's why they have that cutoff of 4 weeks. When we're looking and we want to classify someone's stool consistency, we use the Bristol stool chart. So you'll be hard pressed to find a resident or even a fellow's note that actually documents this classification, but it is actually helpful. And where it's helpful is that patients will describe the same things very differently. So you'll have someone who will describe like a type 4 stool, which is pretty much normal, as being too soft, or you'll have someone who describes a fluffy stool, type 6 stool, as watery, even though it's not watery. So show it to them, let them know exactly what you're talking about. What we're talking about for diarrhea are the bottom two categories, type 6 and type 7. So really mean they do not have an organic cause for their diarrhea. So a lot of the times people with microscopic colitis will look like functional diarrhea patients and or irritable bowel syndrome patients. So you don't want to miss the organic people in the huge wave of people who are functional. When we talk about organic diarrhea, there's certain symptom clusters to be aware of. If you kind of break it down into these symptom clusters, it'll make it easier for you to pick up on important symptoms. So abdominal pain, fever, and bleeding are going to be associated with inflammatory causes. We're thinking like infectious inflammatory causes and IBD, for example. Gas and bloating is something we typically just kind of throw to the side and we don't know what to do with. It is associated with carbohydrate malabsorption. So, and we'll talk a little bit about more about what that means later in the talk, but it is a symptom worth noting. Substantial weight loss, three things in the GI world that cause weight loss: malabsorption, maldigestion, malignancy. Fatigue and night sweats could be a sign of something rare, like a GI lymphoma, and in the setting of diarrhea. And then anemia and change in stool caliber obviously makes you think of colon cancer. So good to keep these symptom clusters in mind. The stool characteristics themselves matter as well. If you're having small, frequent bowel movements with tenesmus and bleeding, then think of inflammation in the rectum or proctitis. That could be caused by a number of things, but the point is that's what it should make you think of. Large volume, less frequent stools suggest a small bowel source of diarrhea. So again, this could be IBD in the small colon or a number of other things, or in the small bowel, sorry, or a number of other things. Steatorrhea indicates either fat maldigestion or malabsorption. So pretty simple, either it's not being digested or it's not being absorbed. And so you're having a lot of fat come out in the stool. Um, and then by history, this is really important to distinguish between, this is important for medicine boards. It's important for when you're rotating in the GI clinic. You're going to be asked about this pretty frequently, but osmotic versus secretory diarrheas. Osmotic or secretory is more associated with diarrhea that's large volume. It's happening constantly, whether or not you're eating or not. So if you're fasting, you still have bowel movements, whereas osmotic typically goes away when you fast. So the history should give you a suggestion of whether it's osmotic or secretory. And lastly, if the nurse says it smells like C. diff, then probably C. diff infection. There's no data to support that. I'm just joking about that. All right. So patient characteristics. Just some big overarching picture type things. If the patient is immunosuppressed, you have to pay a lot more attention for opportunistic infections, the weird stuff, cryptosporidium, and other weird things like that. If you have a traveler who's coming from an endemic area, then you should think of like ova, parasites type thing, other atypical infections. And then if you have a history of constipation, so this is not a go-to diagnosis of overflow diarrhea. It's something that you should be aware of. It exists, but it's not every other patient that you're going to see that has it. So um, if somebody has a clear history of constipation and then they start having diarrhea, it's something that you might want to think about. And then finally, in patients who are diabetic or trying to lose weight, ask about diet foods with poorly absorbed sugar alcohols, and we'll come back to that. Physical exam can sometimes be useful in patients with diarrhea. What we're looking for is systemic findings that would lead you to usually some of these more rare causes of diarrhea. But for example, and these are important to know for your medicine boards anyways, hyperpigmentation may make you think of Addison's disease. With a glucogonoma, you can get the classical migratory necrotizing erythema. Um, Celiac disease, this one's very important to know. Dermatitis herpetiformis is a herpetic-like rash on the skin. Um, and then you can have signs of hyperthyroidism on your exam, um, and then just some other physical exam findings that may tip you off. Okay, so do we have to test everyone with chronic diarrhea? Everyone should probably get basic tests, but not everyone should have the more specific tests. If you have a clear diagnosis and you know what you're dealing with, and there's no red flag signs or symptoms, you can probably get away without doing some of these more specific tests. But if the patient's older, if they have red flag signs or symptoms, if you think you have the diagnosis but you're not sure and you want to confirm it, or in certain cases where you should confirm the diagnosis, like celiac disease, for example, or if you're following a certain lab to assess response. So, for example, again, using the celiac disease example, you're going to follow the antibodies and make sure they come down nicely when they go on a gluten-free diet. Those are all reasons to test. Shotgun medicine is something we're all very well aware of. It's a term that means ordering everything all at once. And we think that we are doing a favor for the patient when we do this. We think it's going to result in less visits, less coming back and forth because you're just going to get everything together. But it's not cost effective, it's not efficient, it can be harmful to the patient. You really, at least for chronic diarrhea, at least for the purpose of this talk, you don't want to practice shotgun medicine. A rifle is going to be more effective. So stool characteristics. So you can have fatty stools, watery stools, and inflammatory stools. Fatty meaning steatorrhea. Watery is just watery stools, and then inflammatory is stools that have like blood and pus in them, and usually associated with pain. So watery stools break down further into two different categories. osmotic and secretory. And when you're trying to differentiate between those two, aside from the historical factors that we talked about, you also can order a fecal sodium potassium, and we'll talk on the next slide about what to do with those. But that can also help you to differentiate between the two. Uh, Fatty stools, you can order a 72-hour fecal fat. That is a tedious study, but it works well. And that means the patient has to collect their stool for 3 days and then bring it in a large container. That'll give you a quantitative assessment of how much fat they have in their stool. And it's a gold standard for diagnosing like fat malabsorption or maldigestion. Sudan stain is a qualitative measure of, it's a spot qualitative measure of how much fat there is in the stool. So they'll be able to tell you if there's fat or not in the stool. And then fecal elastase is a third useful study. This you can use in patients who you're suspecting fat malabsorption, maldigestion due to pancreatic exocrine insufficiency. So if you're suspecting that the pancreas is not working, and that's why the patient has diarrhea, you can get a fecal elastase. You shouldn't get it on everyone. You can get a lot of false negatives on that. So, and you can get false positives as well. In patients who have a large watery diarrhea and you order this, it's going to come back low just because the volume of water is not corrected for. Inflammatory things that you can order. Calprotectin and lactoferrin are great tests, and they've largely replaced the fecal white blood cell, the fecal leukocytes that we used to order. So if anyone tells you to get a fecal leukocyte, they mean order a calprotectin or lactoferrin. Well, the difference between the two is calprotectin is a quantitative measure, and lactoferrin is a quantitative. Sorry, lactoferrin is quantitative. Calprotectin is a number, it's quantitative. Lactoferrin is qualitative. There we go. So, and then infectious stool studies, like Giardia, stool culture, those types of C. diff. Occult blood can sometimes be useful. If the patient tells you they have blood in the stool, you don't need to order an occult blood. You could take their word for it unless you think the patient has a reason to not be telling the truth, or if they're crazy, or if you really want to prove to your colleagues that there's blood in the stool. So briefly on the fecal osmotic gap, when we see an equation in internal medicine, I think we all tend to really shy away from it. And we get very nervous when we see equations. But this is really simple, and gastroenterologists are simple people. So I think this is one that's worth just learning and knowing. It may get you an extra point on your boards, on your medicine boards as well. Um, so in terms of the equation, you have a fecal sodium and you have a fecal potassium. Those are the major cations in the stool. So you add those together and you multiply them by 2 because you also want to account for the anions in the stool. So you've doubled them now because for every cation, we're assuming there's an anion. And then you subtract that from 290, 290 being the expected osmolality of the stool, and that will give you the osmotic gap. So if there is a large osmotic gap, it means that there is something else in the stool that's not an electrolyte that is accounting for that gap. So that should lead you to a osmotic diarrhea. Whereas if there's a small gap, that means you're talking about a secretory diarrhea. So again, large gap means that you have a lot of extra things in the stool that are not electrolytes. So that's an osmotic diarrhea. All right. So AGA has some useful guidelines about evaluating diarrhea. And so these are specifically about what labs to order and what labs not to order. When you have a patient who you think has a functional diarrhea, but you want to make sure it's not anything else. So this is a large group of our patients, actually. We think they don't have anything bad. It's not organic, but we want to make sure. So what should we get? So they said get calprotectin or lactoferrin on all of these patients. Again, those tests are very useful. They have a very good sensitivity. So a negative calprotectin or lactoferrin is going to really lead you away from thinking that it's IBD or even other organic inflammatory causes. They said do not order ESR or CRP on all these patients just to screen for IBD. They're just too nonspecific, and it could be from anything. And what are you going to do with it if it's positive, especially if you're a gastroenterologist? They said test for Giardia in all patients, but do not test for ovine parasites unless they have travel history to endemic areas. And then they do want us, actually, this surprised me a little bit. I wasn't aware of this until I made this presentation, but they want us to test for celiac disease in all of these patients. So the way you do that is you need two blood tests. And just to simplify, I'm just going to give you one way of doing it, which is you get the tissue transglutaminase, the IgA tissue transglutaminase, as well as total IgA levels. The total IgA levels are just to confirm that you have a normal total IgA level and that you're not getting a false negative from an IgA deficiency. So if you get these, this is highly sensitive and it's pretty specific. So this is a good test to do on everyone. And then they tell you to test for bile acid malabsorption if testing is available on all of these patients. That said, it's kind of an unfair recommendation because in most of the US, bile acid malabsorption is testing is not available, and you'd have to do, at best, if it were available, you'd have to do a 72-hour stool collection to measure bile acids. So in terms of a summary of laboratory evaluation, so these are the things that you want to get: CBC Chem, TSH/T4, celiac serologies. You want to get Giardia, calprotectin, and then bile acids where available, plus or minus on the occult blood, plus or minus on the electrolytes. If it's a watery diarrhea, it may be helpful to you. All right. So endoscopy and chronic diarrhea. These are from our guidelines, from the ASGE guidelines, and I'm just going to focus for the purpose of this talk on immunocompetent patients. There is no emergency endoscopy in diarrhea patients, so you're not going to get a scope on a weekend for any of these patients. But reasons to scope in general are if you have unexplained diarrhea, particularly inflammatory and secretory diarrheas get our attention. And then if a patient has red flag signs or symptoms, they'll get one for sure, no matter what their age is. And then patients who are due for routine cancer screening or surveillance can also be worked up for diarrhea with a scope. So if they're 50, they've never had one before, you send them for a scope for screening, and you also get biopsies for microscopic colitis, and you rule out other things. EGD has limited functionality in terms of the workup of diarrhea. You're going to do an EGD. If you have positive celiac serologies, you got to get duodenal biopsies to confirm the diagnosis. If you're suspecting SIBO, you can do EGD with jejunal culture and aspirate. This is pretty invasive to do just to diagnose SIBO. So in practice, what we're finding is a lot of people will just try some antibiotics and see if the patient responds, especially if they have risk factors for SIBO. Endoscopy associated pancreatic testing for exocrine insufficiency. That's for the advanced folk, advanced endoscopists. This is a gold standard to diagnose exocrine insufficiency. They actually go into the pancreatic duct and aspirate fluid, and then they send it for testing. So, and then looking for further evidence of upper GI tract Crohn's disease. Those are really the reasons that you would do an EGD. Video capsule endoscopy is not recommended for any routine evaluation of chronic diarrhea. So the last thing I want to end with, just a few slides on different groupings of etiologies that you could easily diagnose in the office and you could easily fix before even referring to gastroenterology. So if we're paying attention for this, diet-associated etiologies is a big one. And what that is you could break it down to 3 or 4 categories. The first of those categories being substances that in sufficient quantities cause diarrhea in a normal gut. So what we're talking about with that is we're talking about things that will overload the GI tract. Specifically, one thing that we're seeing more frequently in the past 2 decades is fructose. That's because of high corn syrup fructose. And basically, what's happening is you're just pouring tons of fructose into the gut. Fructose is absorbed by facilitated diffusion. And if you have too much of it, you can't do that facilitated diffusion fast enough, and it ends up causing an osmotic diarrhea. Another common cause is sugar alcohol. So these are found in they're sugar replacements and like sugar-free gum and other sugar-free products. And again, they cause an osmotic diarrhea. They're poorly absorbed and they pass right through you. And then caffeine. So what's in terms of what to do with these patients, if you suspect that a patient is having this problem where they're kind of overloading their GI tract, they came up with a validated diet that can really be very helpful in these patients, and it's called the low FODMAP diet. This diet at best is not harmful. You remove a lot of these things that could potentially overload any normal GI tract from a person's diet, and you bring in grains and fruits and vegetables, and patients will actually, if they're able to adhere to this, you'll see a lot of patients improve on it. So something to try in patients, if they don't have red flag signs or symptoms, they're young and you think this might be it, something you can give a shot even before you refer them over. Going back to the slide, though, other categories that are in the same diet-associated category, foods that cause diarrhea due to an underlying condition. So lactose intolerance or lactase deficiency is one of them. And then gluten sensitivity, celiac disease, like we were talking about. Gut alterations that limit digestion or absorption, such as short gut syndrome. And then food intolerances. What I'm talking about here, this is pretty rare in an adult, but food allergies that are chronically causing diarrhea. It happens in kids apparently more frequently, but in adults not at all. Almost, but basically, if someone tells you that every time they eat something they get diarrhea and hives, they should stop eating whatever that is. Um, and then medication causes. So another very important category accounts for 7% of medication adverse effects, and more than 700 drugs are implicated. If you've rotated at the VA in the clinic over there, you know that metformin is a very common offender. And metformin, if you've worked with Dr. Wiesner, you know that he's going to stop before he even starts a workup for chronic diarrhea. He's going to stop metformin and see what happens first before he moves on. And he's had good success with that. Other common offenders are all these things, which you're well aware of. A lot of these things, laxatives obviously can cause diarrhea, and that is confirmed by this Gomer blog article, which shows that a patient cancels a colonoscopy due to diarrhea. Uh, the patient took the prep and started having diarrhea, and then they canceled their colonoscopy. So, post-surgical etiologies. This is another group that you will see pretty frequently in the UC Health patient population, and what different types of surgeries should we be paying attention to? If someone's had a vagotomy, we're not saying this very frequently anymore, but they used to do it more frequently in the past. And what that will lead to is rapid gastric emptying, and that in itself will cause diarrhea. Small intestinal bowel overgrowth is something we'll see after a lot of different surgeries. Vagotomy can cause it in itself because you lose the protective effect of having a lot of stomach acid, and that can cause bacterial overgrowth. Stasis due to strictures or adhesions after a surgery can lead to it. If you have a blind limb, if you have a entocyte anastomosis, or if you remove the ileocecal valve, those are other reasons why bacteria can overgrow and cause problems like that. And just as a reminder for your boards, the diagnosis for this is a jejunal aspirate and culture. That's the gold standard. But frequently, what we do in practice is we'll do a empiric trial of antibiotics. Bile acid diarrhea can happen after cholecystectomy or ileal resection, and that's is basically the etiology of that is important to understand. What's happening is the bile acids are usually absorbed in the ileum, but when you have too much of them coming out at the same time and the ileum can't absorb them, or the ileum is diseased or resected, they pass out into the large bowel. And in the large bowel, they cause irritation of the large bowel and increased secretion. And in that way, they cause the diarrhea. Lastly, short bowel syndrome. Most of you guys are familiar with what this is. You cut out enough gut and then you end up having diarrhea. It's unlikely if you have more than 200 centimeters of small bowel remaining. So that's one thing to keep in mind. But there's a lot of caveats to short bowel syndrome, and it really depends on which parts have been resected, what's left, do they have ileocecal valve left? But this is something else in the surgical etiologies. So that's my presentation. Are there any questions?
So we had two questions from the audience. The first one was trilingual pyramide before doing a workup. Is that something that you guys do?
So you should probably, so if they've had diarrhea for a long time, at the very least, you probably want to do a basic workup. If you're highly suspicious that it's a functional etiology and there's no red flag signs or symptoms, and your basic workup is unrevealing, then yes, you could try loperamide before referring to a gastroenterologist. If they have any red flag signs or symptoms, or they're older in age, then you want to refer them to a gastroenterologist.
Can you just go over the kind of red flag signs or the things that you go over in clinic when you ask people in the first evaluation?
Absolutely, yeah. So blood in the stool is a red flag. Weight loss, severe unrelenting abdominal pains, and then older age patients are people we worry about. So change in bowel habits in people who are older is a red flag in itself.
And then our other question was kind of a similar approach to celiac as the metformin. So do you ever try a gluten-free diet before doing an extensive workup to see what happens?
No, you should not commit them to a gluten-free diet before working them up. So, if it was a resource scarce or resource poor area, like a different country, you might try that. But in the US, it's just too much to commit someone to. It's a very limiting diet to be on a gluten-free diet. So you should send serologies at the very least before you commit someone to that. And even you should have a formal diagnosis, which means if their serologies come back positive, they should have an endoscopy and biopsies before you commit them to that diagnosis or to that diet.
This is Dr. Ram Prasad. I'd like to add a few things and clear up stuff. One of the things about secretory diarrhea and osmotic diarrhea, often people think secretory diarrhea is something very significant and osmotic diarrhea is malabsorption. Osmotic diarrhea occurs only with 3 or 4 things. Like Ahmad said, you have it only when you consume things, lactose intolerance, sugars of sort which you don't digest, magnesium, phosphate, and that's about it. Everything else, it doesn't matter what it is, it's secretory diarrhea, whether it's malabsorption, inflammatory, infectious cause, because there is significant, just like the renal, we have different areas of the bowel exchanging sodium chloride, bicarb, and hydrogen ion. And so we have NHE3, something called downregulated in adenoma, which works through the JAK. And you guys know the chloride channels, including CFTR. And some of them are related to the tight junctions with what's known as pore and leak mechanisms. So there are so many different mechanisms available. And they always, what they do is to keep the osmolarity as 290, just like you do in the serum. That's why osmolarity remains the same. So I just want to make sure, don't want to misunderstand, secretory is something different, significant, and the other things are osmotic. The second thing is the gluten-free diet is not without consequences. First of all, it's very expensive to follow. As Dr. Hassan said, it's not a simple thing to follow either. And the third thing is most people who are on gluten-free diet, they do gain weight. And there have been some concerns about like poisoning from some of the metals and stuff, because when you eat rice and stuff, it comes from the soil, which has a lot of different stuff in it. The last one I wanted to talk about was the stool weight. He talked about central fecal fat. It is a very good test to do because you can see how much weight there is. Normally, we put out only 200 grams. If there is someone who comes with frequent bowel movements, all you want to do is to see whether they really have diarrhea or not. You can see if it's less than 200, that means either they have some irritation. Sometimes women have fibroids, tumors that's pressing on the rectum makes them go more often. So it's a useful test from what I do, and central fecal fat has a lot of information with that too.
We have a question from one of the residents. How common is SIBO? Maybe too generalized of a question, but risk factors look endless. Likewise, how significant of a factor is PPI use? As I feel like nearly every patient carries the diagnosis of GERD these days, whether appropriate or not.
Dr. Armstead, do you want to take this one?
The SIBO, we consider that only in people who have something that is predisposing. Like, for example, if you have a Roux-en-Y for weight loss, if somebody is diabetic and old, generally you have to be elderly to have it if you don't have any anatomical changes. So not everybody should be considered for it. PPI itself, there are so many different things that have been blamed on PPI. We cannot come up with anything that is substantial to stick. Just they published things on showing that dementia was not related to PPI use. It's taking a lot of effort to prove that it's not related to myocardial infarction. And the PPI just does not seem to be at risk for SIBO, even though I can see how the acid is less in the stomach. So not everybody should be considered for it, but under appropriate circumstances, we should probably try it. I don't know if that answers the question.
Brendan was asking about gluten-free kind of resources. Are there any resources that you give patients on gluten-free diets that you found helpful?
There's a lot of lists you can print out. I don't know if if there's any one validated one, but you can find a lot of university websites with PDFs that you can just print out. But you're absolutely right. That's a good point. I had a patient who said he was following a gluten-free diet, but was drinking like regular beer every night, and obviously that has gluten in it. So, yeah, Dr. Armstead, do you know if is there any handout in specific that you use?
Yeah, we do have prescribed diets, but generally they should go to a dietitian and sit with, like you said, they misunderstand stuff, and you should have them see a dietitian. That's a requirement from the guidelines. But there's no dietitian, as far as I know, at the UC, but VA does have one. I may be misspeaking.
The VA does have a dietitian. They'll do a phone call usually with the patient.
We have another question. What nutritional deficiencies should we think about in patients with chronic diarrhea?
It depends on the cause. So, if it's celiac disease, and it's active celiac disease and they have the full like villus blunting and everything, they're gonna malabsorb a lot of things, iron, and vitamin D even, and other vitamins. In short gut syndrome, I think it depends what's resected. Um, if the ileum is resected, then it's the things that are absorbed in the ileum that you would expect to be deficient in.
Well, if there are no other questions, I want to thank you guys for coming by. And I'll send this lecture out to the rest of the residency, anyone who missed it today. And thanks. Tomorrow we'll have IBD with Andrea, our former resident here. So I'm excited for that one too.
All right, thanks everyone.